mentioned in the program. So Miguel Montero-Baca will give his talk about assessing foot perfusion after BTK revascularization, role of perfusion, angiography, and upcoming techniques. Miguel, please.
Thank you, Dr. Seller, and I apologize to the audience, but the lunch symposium ran over a little bit, so I was on the podium over there. Some important disclosures. I do have equity in this company. I've been working with them for approximately 60 years. They're based out of San Francisco, and we'll be talking on a couple of technologies that have to do with that company. Now, the term perfusion is derived from the French verb perfuse, and it means to pour over or through. And it's really flow. When you look at it, it should be a volume per unit of time, like, for example, liters per minute. That's flow, but perfusion really should be milliliters per minute per gram. And so why is that important? Well, because I think that we're all seeing here today that with the development of all the robust skills that you've seen everybody show, and the more appropriate technology, operators are obviously able to treat more complex and more distal disease patterns. Now, this perfect storm of technical skills and advanced tools makes the question, what's possible, rather irrelevant, and the question, what's appropriate, extremely relevant. And I think the way we view things is there's probably two major ways to look at vascular disease below the knee. One is a transport problem where you can't get flow down to the ankle arteries, seen in below the knee disease, diffuse, and some below the ankle disease. But then there's also patterns of problems with distribution, which we see in patients with severe renal failure and long-standing diabetes, where the problem is a below-the-knee microcirculatory disease and certainly an end wound perfusion problem. So this is just an angiogram to show a problem with transportation. And this guy's got some tibial disease, but look at that. Look at the arteries at the level of the foot. Sorry, I'm trying to get that right. There you go. Look at the arteries at the level of the foot. I mean, these are beautiful arteries that are intact, and there's good blush all over the place. On the other hand, this person has some flow all the way down to the ankle, but then it stops, and then all you have is all these squiggly vessels all over the place, and you really don't know if they end up going somewhere or if they're effective in the way that they transport. So there seems to be a problem called ischemia. Then there's this magic threshold we're trying to achieve to make somebody non-ischemic, or at least to make that region of the foot non-ischemic. And that depends a lot on the patterns of disease, on the wound and the wound care that's going to be applicable to that person in particular, and then the comorbidities and certainly things like nutritional status. So that magic threshold may be dynamic in nature and may not be the same thing for a small little dinky wound than for a big exposed calcaneal heel necrosis. Now, when we look at transportation on table, what we're trying to look at safety and efficacy, what we have now to determine our procedures as safe is angiography by means of looking at the wound blush, 2D perfusion software, and then micro-oxygen sensors as they're emerging as a good technology to assess our procedures. Why? Because the goal is to do the most limited procedure we can, but have the least amount of contrast and radiation and know that we did a good job for the patient. And that may be just opening one single correct vessel below the knee. In distribution, the same three things that I think are worth mentioning, but here the primary goal, other than the limited issue, is going to be to know if you know ahead of time and early on if that patient had failure of the intervention, because that may lead you to be more aggressive with either a deep venous arterialization or, in some specific cases, maybe a major amputation. So we have a lot of data from Japan coming that's very interesting, and this is just an extract from one of the papers in 2014 from Professor Yu, where he says, whether or not direct flow based on the angiosome concept was achieved and how many crural vessels and below the ankle vessels were successfully treated did not predict wound healing. So it's not about if you could get 3 open, it's about if you could get the right one open. And in this case, he said wound blush was the key. And look at this nice follow-up in 2017 JACC, where when you had a wound blush, this effectively correlated with better wound healing. So if you get a blush into the angiogram, you're going to actually do better than if you don't get a blush. And this is just an angiogram to show that that's a wound blush, positive wound after an intervention. Now, shortcomings here is it seems like a black and white approach. very subjective to threshold. And if you ask me, I've seen a lot of these wounds that have a blush even before the intervention. So it's hard for me to tell what's a good wound blush positive versus a bad wound blush negative. Now, this may be the answer to that, is what if you quantify that blush? What if you make an algorithm that it adds not only the contrast, the resolution of the pixels of the contrast, and then the velocity at which that contrast is uptake, and then digitalizes that into a curve that could be interpreted, not only by the means of its curve itself, but also by actually giving some therapeutic physiologic stressors that could change the way these vessels open up and down. Now, shortcomings here, there's a lot of artifact. Any patient that moves on a table will screw up the 2D perfusion. It's a non-validated threshold, and there's unexplained lack of responsiveness in a lot of BTK intervention. And on top of that, I believe that some of the ongoing studies are a little questionable when it comes to the sign. I don't think they're looking at the right stuff. Last but not least, I'd like to share a couple of slides on the advances of micro-oxygen sensors. This company is called Perfusion, and the microsensor is called the Lume. And this sensor is injected into the subcutaneous tissue, and it has some porphyrin particles that when you excite it with a light, it's going to emit a signal that is going to be proportional to the amount of oxygen molecules within the milieu in which the sensor lays. You see there somebody doing the reading after the implantation, and then you see the cords attached to the foot of the patient while the intervention is done. Currently, after a first-in-man study many years ago in Latin America, we're now moving forward with it, since it's got the European safety mark. There's a study called Omnia, which is oxygen monitoring near ischemic areas. This is a prospective, single-arm, open-label, multi-sensor study. And the idea is to continuously see at Lume's oxygen content response during revascularization procedures. And then there's some also physiologic stressors that are done to the leg, like raising the leg or lowering the leg or putting a cuff up and seeing what the response of that reperfusion does. Now, what's interesting is that we're being very critical about how we see this. We're actually looking at the duplex, at the toe pressures, at the ankle brachial index, at the Wi-Fi scores, the wound characterization, and then photographs in every one of those times, including 1 month, 3 months, and 6 months. These are the rock stars currently enrolling, and hopefully, if the FDA does give us permission, we can start soon enough in the US too. As of today, we have 21 subjects enrolled in this particular study, and as you can see, most of them have all CLI. This is a CLI study. This is the type of information that you see from Lume intrasurgically, and you could see how the oxygen content at the beginning becomes low, and as you start doing the interventions as placed by these yellow columns, the oxygen starts significantly increasing. And now the more close to the ischemic penumbra of the more close to the artery that you're intervening, the more the uptake becomes interesting. This is just one of the patients to show how much the Wi-Fi score is viewed at, how much the toe pressure is viewed, what specific treatment that patient got, what the Lume showed intraoperatively, what the patient showed clinically, and then all the pictures that allow us to follow this patient longitudinally. Now I'll close in my last 30 seconds here by saying the interesting with just these 21 patients alone, we found clusters of reactiveness. Those patients that have much more increase in the intraoperative have actually led to improvement, where those that don't have that much or stay the same either do the same or do worse. So you could see that at 3 months and at 6 months, and then follow those that didn't have a change and those that did have no change at all are showing some remarkable changes. So there's a desperate need certainly to establish objective performance goals for on-table decision-making that may lead to optimal clinical outcomes. Intraoperative data, although somewhat cumbersome right now, may help decide plan of care. Wound blush, 2D perfusion, and oxygen sensors are potential tools that may show promising preliminary data. And thank you very much. Remember, you're all welcome in Houston. Anybody who wants to come and play with us, we have a cowboy suit for you. Thank you very much, guys.